Good morning, everybody. This is Denise Easton. I am the chairman of the board of Plexus Institute and the acting executive director. And I'm very excited. We've had a number of pop-up conversations, and this particular one with Nancy Suchman is on mothering from the inside out. And what's really critical about this is Nancy has been working on some really exciting projects on how to change how mothers with drug addictions can, one, build more productive and adaptive lives for themselves and their babies. And this just falls right into a sweet spot where Plexus has always been interested in finding new ways to address these persistent problems we have in a number of issues and communities, including healthcare. So without further ado, I'm going to mute myself. Welcome, Nancy, and I'm really excited to have you here. Thank you so very much.
Thank you, Denise. I'm excited to be here too. Thanks for having me. My name is Nancy Suchman, and I'm an associate professor at Yale University in the Department of Psychiatry and Child Study Center. And I'm also a licensed clinical psychologist. And for the last 20 years or so, I've actually been really interested in studying the parenting practices and experiences and problems of mothers who are in treatment for drug addiction, primarily opioid addiction, but also cocaine and other substances as well. And so I've been developing and evaluating a parenting intervention called Mothering from the Inside Out. And just a brief background on the development of the intervention. About 20 years ago, I was just starting to, dip my toe into the intervention research, finding that a lot of the evidence-based parenting programs for mothers in the general population were not working for this population. And what we found is that just sort of as a treatment model, usually the parenting interventions that were being developed were really being developed for kids who were hard to parent, not for parents who were struggling with their parenting. And so the patient of focus was always the child, and it was targeting things like conduct disorders, children with oppositional defiant disorder. What we've found, or what researchers found, was that parents with significant addiction and psychiatric problems would generally drop out from these programs and not stick with them. And so we decided that we needed to learn more about why mothers were dropping out. And I, in particular, was interested in understanding why mothers were, how mothers were thinking about parenting on the inside, and how that was affecting their parenting behavior on the outside. And so I did some sort of digging around and started learning about attachment theory, and then started learning about this concept of mentalization, which is really the parent's capacity to make sense of their own emotional experiences in the parenting role and their children's emotional needs. And it's related to attachment theory in that if you're familiar with attachment theory, and John Bowlby and Mary Ainsworth, their work has shown that children need to have a systematic way to get proximity to their parents when they're very young in order to feel secure. And that's what we call a secure attachment, when children, starting in infancy and then sort of culminating at around age of 12 months of age, infants develop with their parent a systematic way of communicating, really, about the infant's emotions in a way that the parent can respond to in a timely way and not a very stressed out way, so that the infant can have their emotional need met, particularly the need to be emotionally calm and regulated and secure. And so one of the things that we were then learning about mothers who were in treatment for addiction is that they really struggle to regulate their own affect. In fact, that's one of the reasons why we think they end up getting involved with using drugs in the first place. And then the addiction process is actually a neurobiological process where chronic substance use over time actually changes the brain chemistry so that the brain no longer provides the emotional rewards that we experience in everyday activities that are necessary for survival. So, like eating and sex and social relationships, including parenting, are naturally rewarding. And the best way I can illustrate that is when you have a child walk in the room, oftentimes people light up and they get excited and delight in the child. And part of that is a surge in their dopamine or other neurotransmitter or their oxytocin that's creating this internal sensation of pleasure. So there's a biological component to that. Well, in the case of mothers with who've been using drugs chronically, the drugs have co-opted that system so that it now takes a lot more and more of the substance to get a normal reward response. And because the brain kind of adapts to being flooded by the substance so that it stops producing so much dopamine. And so as a result, normal experiences like caring for your child are suddenly much more stressful and not experienced as rewarding. And I was just reading today, we now have the first study published in 2017 in a journal on mapping the brain that shows that mothers with chronic addiction, when they see pictures of their own infants smiling, they experience less reward. So it lights up the reward centers in the brain that are associated with oxytocin production and dopamine production light up less when they see their own infants' happy faces than when they see an unfamiliar infant's happy face. So if you think about that, that's it's pretty profound that we now have neurobiological evidence that one's own positive infant emotions are registering less if you have a background of addiction than compared to mothers who don't have a background of addiction. Is that making sense? Okay. So
actually, Nancy, I have a question.
Sure.
It does make sense. Thank you. And what is the correlating differences for people who are not addictive? So a mother who sees who is not an addict, who sees her child smiling versus just a random child smiling. Do you have that information? Could you share a little bit about that, please?
Yeah, there's a lot more research. There's a lot more research that's been done with mothers who don't have histories of addiction or psychiatric illness. And they show that when they see pictures of their own infants smiling, then their reward centers in their brain become activated, more so than when they see unfamiliar children. So the idea is that there is something that has, there's something particular about your own child that activates your reward center in mothers without addiction. Does that clarify?
Yes, thank you. Yes.
Okay. So, then, given that we have mothers who are, coming into treatment, lots of times motivated by their role as mothers to come into treatment, but unable to experience the pleasure of parenting and therefore experiencing quite a bit of stress in parenting. We felt that an intervention really needed to be developed to help them manage and regulate the emotional experiences of parenting in the moment so that their stress doesn't become activated. Because once their stress becomes activated, we think they kind of enter into a fight or flight mode, and they either want to get away from their stressed child or the emotional distress of parenting, or they want to try and control it. And we think that's where child maltreatment can come into play, where that's really a mother just trying to control what she's experiencing as a noxious stress. And it's hard to, it's really hard to wrap your mind around this, but I think I've sat with enough mothers who are experiencing addiction who tell me, I just don't get it. My child should be registering, you know, should be enough of a reason to not pick up and use, but for some reason she's not, and I just don't get it, because I do really love her and I really do care about my parenting. And so we went to attachment theory and to this capacity for reflective functioning or mentalization in particular, which is really just a big word for the ability to kind of tune in to your own emotional states when you're stressed, and to also tune into your infant's emotional states when your infant is stressed. And this capacity to do this is actually a skill that can be fostered in a therapeutic context. And we were wondering if we, rather than teaching parents how to manage their children's behavior, if we try to promote this process of tuning in when you're distressed, will it help the mothers in their relationships with their children, and also will it help them with their own propensity towards relapse while they're in treatment? And so the actual therapeutic process it's quite flexible. And the idea is that the mother comes into an individual therapy session with a trained therapist, and whatever stress is on her mind is where the focus of the session goes. And the therapist, rather than telling the mother how to solve the problem, will become curious about the mother's own mental and emotional experience of the problem, and try to help her have a better sense of her own emotional experience, because that's actually a way of becoming more regulated. So if you think about it, if you have, let's say you're in getting into an argument with your partner, and your partner comes home and gets mad at you for putting the coffee pot in the wrong place. If you didn't have this capacity to think reflectively about your own mental state and your partner's, you might react and escalate into an argument. Whereas if you have this capacity to say, whoa, what he's saying is really, I'm really getting annoyed right now and I'm feeling like yelling at him, but actually, something might have gone wrong in his day. So I'm just going to slow down, take a step back, and see if we can talk about this and realize that his stress isn't about me, it's about something else, something like that. Then you're much more able to regulate that. And this is a skill that many of the parents that we work with, for a variety of reasons, not just their addiction, but it could be their own developmental histories and relationship histories, that they don't have this capacity as strongly. And so that's really what Mothering from the Inside Out focuses on. And so, usually our first step is to help the mother regulate her own emotion, think about her own emotional distress, and then to help the mother focus on the child. So if it's a parenting situation, and say the mother comes in and says, my daughter Annie, she made me late coming to the clinic today. She knows better. She's doing this on purpose. This is a 2-year-old who's not really doing this on purpose. And I'm going to punish her. I told her she couldn't play with her doll when she gets home. Stress and saying, you're really frustrated. What is that about? And she might say, well, if I know if I don't come and get in line in the methadone clinic, I'm not going to get my methadone, and then I'm going to go into withdrawal. And so we'll explore the mother's own emotional reaction first. And then when we have a sense that the mother has experienced herself as understood by the therapist, then we'll shift the focus to the child and say, well, so, and what about Annie? What do you think is going on for her? That she didn't want to leave just then. And then we'll try to bring the conversation into what's normal, a normal response, that it's sort of normal for a 2-year-old not to be able to make a transition from one activity to another, that she might have been really engaged in what she was doing, and that she might need a little extra help in making that transition. So there's a combination of mentalizing for the child, thinking about the child's emotional states, and then also bringing in some developmental information that might help the mother understand what developmental stage child is at. And so we've studied this intervention in 2 randomized clinical trials where the mothers are randomized to either MIO, mothering from the inside out, or to an active comparison, which is where it's more of a traditional parenting class where the mothers can choose the topic. And it's usually a stressful parenting situation or parenting challenge like bedtime or nutrition or power struggles. And we have a whole series of pamphlets that we've developed that counselors can go over with them. And so in the 2 randomized trials, we have found that mothers in mothering from the inside out show a better capacity for reflective functioning, for thinking about their own emotional states and their children at the end of 12 sessions of MIO compared to the mothers who have 12 sessions of the parent education. And then we've also found that their interactions, we actually videotape their interactions with their children to look at whether improvement in the reflective functioning is related to improvement in their parenting relationship. And so without giving them a lot of specific instruction about how to interact with their children, we found that they just kind of figure it out once they can think more clearly and calmly about their children's emotional states. They can become more sensitive and responsive. And these are young children. So they're children between the ages of 1 and 5. We also found that mothers who were in MIO showed a lower propensity for relapse to opiate use by the end of the study. And so we were encouraged to see that improvement in this capacity for reflective functioning was related to improvement in abstinence, and they're reaching their goal of abstinence. All of the mothers in the study were enrolled in comprehensive addiction services. So MIO, it's not a standalone treatment, it's more of an adjunct to addiction treatment that the mothers are already enrolled in. And so now what we're doing, we're about halfway through a 3rd randomized trial where we're training the addiction counselors in the addiction treatment clinics to do both interventions, mothering from the inside out and parent education, because we want to be able to provide this service under the same roof where mothers are getting treatment for addiction, rather than them having to go across town to a child development clinic where they're worried about, potentially losing their children or having people who don't understand addiction treat them. And we don't know the outcomes of the study yet in terms of the treatment outcomes, but we do know that the counselors are able to learn to provide the intervention with what we call fidelity. And we videotape the treatment sessions, and we provide ongoing clinical supervision. And so it seems that even though they're not child development specialists, are able to learn enough about child development and about the mentalizing skill to be able to do what they need to do to foster that capacity for the mothers. But we're still waiting for the outcomes of that study. So I guess I could leave it there, and that's sort of what we're doing in a nutshell, and open it up for questions or if you need clarification on anything.
Thank you. Hi. This is fabulous. I mean, I've been typing questions away that I'm very interested in, but I do want to also open it to anybody else. And yay, Frank, thank you for, I'm going to unmute you now. I'm happy that you're here. Frank and Nancy, I've tried to introduce the two of you at several points. Frank is in New London and is working diligently with the community and addressing a number of the opioid issues. So we're all in the same area. So I'm really delighted to have you here, Frank. And this is an introduction. But several questions that I have really look at the larger system in which the mothers are part of. And so part of that, as I've been typing in there, are you including any of the family? I understand with the randomized groups you can't, but are you including the family? So fathers or you know, the caretaker, the other people in this reflective training? And if you could share anything about that, it would be really interesting to hear that perspective. And then I will be quiet and allow anybody else to either type in or to jump in with a question.
Sure. I think it absolutely makes sense to include partners and extended family. Oftentimes you have mothers getting help from their own mothers and aunts and uncles and relatives and caring for their children while they're going through treatment. Because we have a specific research protocol, we're kind of obligated to test one model at a time. And so we've just, made the choice to rigorously test the intervention with the mother in order to have a quote unquote clean study that provides the data on whether the intervention is effective with the mother. And then, but I think there is lots of room for including and a lot of good reasons to include the family system in the model in a real world clinic setting. And if I were a clinician practicing in a community setting, that's certainly what I would do. The other part that I didn't mention is that as part of our research lab, we provide what we call developmentally informed childcare to all of the children of the mothers who are coming with the mother in tow into the study and into our clinic. And so I do think our intervention extends to the children because of the interactions that they're having with the counselors, and also because it gives the dyad a chance. There's sort of natural reunions and separations that happen while the mother is in the therapy session. For children can come and go, and we have a chance to kind of observe them and comment about what's happening, what's taking place between them. So in that sense, the child can be somewhat included in the process as well. But there are other programs that have a similar focus that go into the home. There's one called Family-Based Recovery at the Child Study Center, where the clinicians go into the home and have interactions with the mother and other family members and the child. So there's a little more openness in that. Did that answer the question?
Oh, it absolutely did. And I know Barb Siegel has a question that I'm going to let her ask, and then I do have another one, but I don't mean or should be the only voice. So Barb, jump on in.
This is sounding like a little bit like behavior design and a little bit like Dan Siegel's Mindsight. And so I'm wondering, it's kind of a mashup of those concepts, and I'm wondering if there are extensions of the idea of mothering from the inside out that could be applied to non-parents as a addiction treatment, and if there are any out there.
Oh, to non-parents as an addiction treatment. That's a good question. I don't know of any yet that are being applied to non-parents, but I think it's definitely, ideally, we've thought about a good time to start doing mentalization-based treatment would be with young adults before they have children. Young adults who are in treatment, because the process of becoming a parent psychologically starts a lot earlier than when your child actually is born. And so we thought about having mentalization-based groups where with young adults where they have a chance of thinking about more about reflecting on their own feelings and intentions in relationships as a way of helping them make good decisions about coming into relationships, and sort of putting the hormonal and sexual drives into a larger context in terms of what it is that they're hoping and seeking in relationships, and what it's like to be experimenting in different relationships. So I think there's definitely room for it to expand. Traditionally, mentalization was a concept that was developed by a psychoanalyst in London, Peter Fonagy, who developed an intervention for working with patients who have been diagnosed with borderline personality disorder. And again, because of the need to recognize and regulate strong emotions that come up, particularly for patients who carry that diagnosis. And so, that intervention is called mentalization-based therapy, and that has been adapted beyond individual work with borderline patients for working with families as well in the UK, particularly at the Anna Freud Center. So that would be a good source for learning about how it's been applied in other populations.
I'm actually wondering, as you're talking and you're suggesting that mentalization is very helpful in picturing yourself in relationship, that this could be an incredible middle school intervention, given all of the efforts we're seeing right now about, yes, there will be more money for schools and mental health, and also the money that's available for addiction treatment that catch up upstream, which is what everybody wants to do.
Right, exactly, as more of a preventive focus. I agree. There's a related effort in the field of emotional intelligence to bring that into schools. But the thing I really like about mentalization is that it kind of helps an individual connect the dots between their reactions and what's happening in their relationship. And it helps them understand how other people are seeing them, and it helps them think about other people on the inside, which are two things we don't often do as easily. Knowing our impact on others, and also thinking about others, not just in terms of their behaviors, but in terms of their intentions and their internal experiences. So I think it's a brilliant idea. And children actually start developing this capacity as early as age 2. If you think about how a 2-year-old is just beginning to be able to adopt the perspective of another person, so they can say, well, I like strawberry, but my sister likes chocolate. If you think about that, that's really a building block for mentalizing. It's when the 2-year-old is developing an understanding that others have a mind that's different than their own. And then it takes off from there. And we think that it's so crucial for parents to be engaging in this process with their children, because it helps their children at a very young age begin to understand their own affective states rather than be critical of them. They can start to recognize, oh, that feeling is angry, and that's an emotion. It doesn't mean I'm bad. So it really has a lot to do with forming a coherent and positive sense of self at a very young age. And we think it happens in the context of a secure attachment, where the parent is able to, not 100%, but enough of the time be able to mirror back to children their own mental state. So we begin to develop an awareness.
Nancy, are you, and understanding the rigors of the research protocol, Are you planning, or are you working with any groups who are starting to take this in a less research-oriented protocol into varying communities and with groups, sort of as beta testing it, where you could do families? One question earlier on was whether there were any training groups that had mothers, but both addict mothers and non-addict mothers.
Right.
And so if you could share any of that information, that would really be terrific. And thank you.
So as much as I can as a researcher, I have tried to push the envelope a little bit to do some sort of experimental research in the community. And so I actually was invited to train psychology trainees in a state-funded mental health clinic that sees children and parents. And so for about 3 years, I provided training and ongoing clinical supervision to trainees in this clinic, who then provided the intervention with their patients. We actually started out by running a group together so they could see me using some of the techniques, and then we turned it into an individual intervention, and then we actually were able to collect data. So that was one example of sort of bringing it into the real world, having a chance to kind of learn what the clinician's response was to the intervention, and also learning how it went with their work with the parents. And then another sort of long-standing consultation I'm just finishing up is with a group of about 11 treatment providers in the Western Cape of South Africa. And they represent, they work in 4 different tertiary hospitals where patients that tend to treat patients who are of mixed race or Black and low socioeconomic status. It's sort of where public treatment is provided to people who can't afford private treatment. And this group wanted to try to adapt the intervention for working with a really interesting range of mothers. So one of the treatment units was mothers of children who had just been treated for significant burn injuries. Another unit was mothers who had delivered infants prematurely and were inpatient on a premature infant clinic receiving in a kangaroo care program. And then another group was mothers of children with significant developmental disabilities. And then there was also a group of mothers with addiction and psychiatric illness. So it was a real wide range. But we decided that the mentalization approach was similar to all of the populations. And so we trained everybody as a group and then provided some individual supervision as well. And again, the intervention was really well received overall by the mothers. We also tried different formats. Some were doing groups, some were doing individual, some were doing groups twice a week, some were doing groups once a week. So we really allowed them to take the intervention and then just adapt it to their own setting. And we did collect data in both of these mini trials, and we're continuing to find really good improvements in reflective functioning and in many cases the parenting relationship. So there seems to be something about the intervention that is being helpful to the process of parenting, and now we're trying to find out what actually are the mechanisms. So you can imagine just having a close relationship with a clinician is a really important part of being able to, develop psychologically on your own. So we're looking at those mechanisms. But and then I have, people who've been training with me who then go and develop their own mentalizing group or individual intervention in their own real world settings. And so I think it is starting to starting to take off. I think one of the challenging things is figuring out the balance between, for the clinician to figure out the balance between how much do I focus on mentalizing and how much do I focus on the real problems that my patient is having from week to week. And we've, found you can't be doing all mentalizing all the time. So you have to find the right balance, depending on what the problems and needs the patient is coming in with. I also have a colleague who's trying to bring this to training primary care physicians working with parents to help physicians use their own mentalizing skills to get at what some of the concerns are the parents are coming in with. There's a really nice book by Claudia Gold, who's a pediatrician who's been doing a lot of work with in primary care visits, where she's written a book for parents about the same process. The title of the book is escaping me, but if you looked up Claudia Gold, you'd find a really nice reference for that.
I would love to hear you talk more about how parenting begins before the child is born, and how much legitimacy is seen in that in the research community.
Yeah, that's a really good question. So from an attachment point of view, what attachment researchers and theorists understand is that children actually begin forming their idea of, or a prototype in their mind for the parent-child relationship in early childhood, based on what they experience with their own parents. That somehow they develop a kind of a mental prototype or a mental representation of what a parenting relationship is, that then surfaces when they become parents. And so, the adage, we parent the way our parents parented us, is something that we see a lot of in working with parents in our clinic, that they end up repeating or getting stuck in the same places that their own parents were stuck with them, and that they encounter similar kind of blocks in their understanding of children that their parents had with them. And so this is more of a developmental perspective. You could say maybe, it's also psychodynamic perspective a bit. But I think that the research community is just starting to come back around and realize there is some, and it's interesting because it's happening a lot through the brain science, finding that there is support in neuroscience for some of these tenets about emotional relationships and how enduring they are. So we try to, to understand how a parent has come to their parenting style quite honestly through the experiences that they've had. And it's not something that they're trying to be malicious about, but it's really the best that they can do. And that a lot of these parenting behaviors have become automatic. It's sort of like their reactions that were learned based on how their parents reacted to them. And so they're not necessarily conscious. And sometimes it's even justified, that children should be hit or punished or put in timeout. And so even though they're enduring representations that may make parenting more problematic, it takes a while to bring them into awareness and actually promote their change. So one of the tides that we're fighting against is that you can't just provide an intervention in a classroom setting. It has to take place in the context of a therapeutic relationship. And yet that's more labor intensive and more expensive than, say, the group modality that's the state of the norm right now in drug treatment clinics. In fact, in the drug treatment clinic where we do our research, the patients don't even have an assigned counselor. They come in and meet with whatever counselor is available. And so you can imagine that, anybody who has to meet with a different doctor when they go into a clinic visit knows that that can really stir up anxiety if you haven't formed a certain rapport. And so we're trying to show that in the long run, it's going to be more cost effective to put the resources in up front to provide a relationship that really allows for change on a deeper level under stressful circumstances. And that's really going to allow a patient to be more resilient going forward. So hopefully the pendulum is going to swing back around in research in time. And it's encouraging. There is more and more research focused on this concept and a lot more interest in it since, in the last 20 years. So,
I have a question. Is there research or are you planning research that would show whether mentalization actually makes changes in the brain in the same way that the drug abuse does?
Yes. Fortunately at Yale, there are a lot of neuroscientists who are interested in this. And so nothing has been published yet, but they're starting to, the neuroimagers are starting to hook up with the intervention scientists saying we would like to do brain imaging before and after, including our study. We're beginning to develop a collaboration with Helena Rutherford here at Yale, so that I think in the next 5-10 years, you're going to start seeing this research, because nobody quite knows when does the brain reset to a natural reward system, how does it happen, what interventions promote that. And so I think that's going to be the next wave of science, and it'll be really interesting to see. I can say anecdotally, I have seen patients in recovery who move from, kind of having sort of no emotional response to their children to being able to delight in and have a normal, healthy preoccupation in their children. And whenever we see that in the clinic, we feel very reassured, because we know that this little girl or boy is now on that patient's mind, and they're delighting in each other. And that's going to be a very strong incentive that's going to help the mother to stay clean. So, but that's just anecdotally from clinical experience.
And there's a lot of research that you've mentioned in your papers that people who grow up with drug-addicted parents are more prone to use drugs themselves. So what would have to happen to make this kind of treatment have a generational impact that would protect over?
Yeah. Yeah, no, I think that's a good question. And I think that that there really needs to be, a shift towards valuing this capacity in educational settings and in preventive settings and in sort of everyday settings that parents find themselves in. So, and one of the things that we're doing to try to promote that is we're now training all of the addiction counselors in the 3 clinics where we do our research in a very basic protocol in child attachment, so that they're sort of speaking a common language when they're working with parents in the addiction treatment setting, where if the parent comes in stressed about something with the child, the clinician now has a background in attachment and how to promote healthy attachment so that they can engage with the mother, and the mother can have that conversation with any of the clinicians in the clinic. So I guess it's a long way of saying, change. I think change really needs to happen at the population level, in the community level, earlier than it does now. Does that
Yes, that's it does another sort of side component that is there research on whether methadone, suboxone, and some of the other treatments have the same or similar impact of hijacking the reward system that the drug does, so that then the person needs it, but they have another barrier to try and deal with.
So what we have found is that even with most of our patients actually are in methadone maintenance, and then a smaller percentage are receiving suboxone. And so the harmful thing about heroin is that it's not, it's usually used in a way that's inconsistent, that changes the levels constantly in the brain. And whereas with methadone medication and suboxone, a more sort of stable level of a stable level of medication is achieved, so that it's not really wreaking havoc on the brain in the same way. Also, methadone doesn't produce the same euphoria that heroin does. It just really helps prevent the withdrawal symptoms from becoming activated and then producing the cravings, that then cause someone to go out and relapse. So it's the methadone and the suboxone we don't think are hijacking the brain in the same way as the heroin. And we've found that we do see improvement in reflective functioning in patients who are using methadone or in methadone treatment and in suboxone treatment, as well as patients who aren't receiving any drug replacement therapy. So it doesn't seem to really be an issue.
Good. Thank you.
Sure.
A quick question. I don't know if Brooke is in a position where he can ask it, so he did type this in. And he wondered if there were any differences between male and female children or male and female parent adults. And I understanding that was not part of the, sort of the research protocol. But if you could share anything that would be terrific. Thank you.
Sure. In terms of parenting, what gender the child is, we haven't found differences for mothers of boys and girls in terms of response to treatment, although there are different ways that they think about their children that are gender-based. But in terms of fathers versus mothers, the research on fathering in addiction is a bit behind the research on mothering, although there is a researcher at Yale, Carla Stover, who is developing and studying a program also with NIH funds called Fathers for Change, which is it's actually an intervention for fathers who have issues with interpersonal violence, substance use, and child maltreatment. And so it's combining, it's really a program to help fathers regulate emotion related to all of those issues so that they can become engaged in their relationships with their children. But right now, we don't have any brain science research on fathers with addiction yet. However, there has been some really interesting research doing brain imaging of mothers versus fathers around the time of the birth of their infants. And there do seem to be some differences and some changes that happen in mothers after they've given birth that don't necessarily happen in fathers. And in a nutshell, and the researcher to read about this, in terms of the technical aspects is Randy Swaim, Swaim. And what they basically found was that something happens in the brain after birth where mothers are much more attuned to their infant's cries, but that the same thing doesn't happen in fathers. And so we don't know why. You can speculate, but it does seem to be that there are important gender differences to look at in terms of the basic neurobiological mechanisms of parenting and how those mechanisms change at the arrival of a child. I think that's the best that I can explain it. But for many of the mothers, most of the mothers that we're working with aren't in stable relationships with partners, but for a significant number of them who are in relationships, there are significant problems in the relationships. And so I think there is definitely a need to bring dads into the mother's treatment as a way of supporting the mother and also supporting the father and supporting the parenting for the child. Because oftentimes the conflicts in the relationships end up sort of gobbling up psychological space that the child really needs for the parent to have.
Thank you. And I'm not sure if Brooke wanted me to say that ask this, but I do what he said to me privately. Assume that male behavior and attachment changes are built over time versus the mothering, and that may be a direct correlation to the, as you said, as soon as the child is born, that there are changes with the mother versus the father for a multitude of biological as well as psychological reasons. Mm-hmm. Fabulous. So as we're winding up, as usual, this is always so exciting and a tremendous conversation, and we could probably keep going. But if anybody would like to pop in with a final comment or question, please feel free to do so.
This is probably too big a question for a quick answer, but there's a lot of studying that shows opioid related to desperate situations and people who are just basically self-medicating out of miseries. So what would address that? I mean, how would anything happen to reduce such dependencies or attractions of opiates?
That's a really good question. Well, I think if you think about, it's a really complicated it's a complicated issue because once you have a patient who is, people may get involved in drug use for one reason, but then when addiction takes over, it's got a life of its own, so to speak. But there's plenty of evidence that patients who pick up drugs in the first place, many have histories of exposure to trauma starting in childhood, and so and that the seeking out drug is a way of seeking out sort of a restorative emotional experience when relationships haven't really worked for whatever reason. And so, again, I think that there is a lot of room for supporting people's capacity to benefit from relationships early on before the onset of opiate use, which typically is in the late teens, early 20s. Then once you're in the current opiate crisis, another large cause of addiction has been there are more and more patients who are gravitating towards opiate addiction from prescription drug use, and so that's a whole nother another issue that is being addressed. But there's a very strong correlation between early trauma and later addiction. And so, and early trauma has a lot to do with the formation of unsafe relationships and not being able to develop a secure attachment or a clear set of expectations for healthy relationships. And so I think, that a lot of work, there's still a lot of work that needs to be done there.
And with that, two things. One, hope you'll come back and talk to us as you're doing new research and work. And I'm pretty certain folks will be reaching out to you. I know I will. But thank you so much, Nancy. It's tremendous work. Thank you for your time today. And we hope you'll stay involved with Plexus and the network. And thank you to everybody for joining us. I am going to stop the recording. And
you have any other questions?
Thank you very much.
That's a pleasure.